I have no idea what they're talking about. Yeah, so that's what like yeah, and also it's hard. Yeah, I was I know. I go back and forth. Yeah, Yeah. Yeah. You look easy. You wanna, yeah, I Yes. Okay. Yeah, I'm an engineer. I with Dig I joined over along with Al. Yeah, I would like to all of these to some.
Go again. Here's my card. Really nice to speak with you.
Yeah, thank you. All always email me if you have.
Yeah, I will. And if you think Deloitte could be helpful in any way to what you're doing, I was checking out Digdeep's website. Really.
Perfect.
Cool
Yeah,
stuff.
thank you. We appreciate it. Thanks for coming. Nice to meet you. Thank you. Yeah, we're doing a free bus pick and then.
But you should be in the.
Here's okay, I'll send it to you. Okay. That's not even fine, that's sometime, but I'll figure it out. I've heard about it. Is that yours? Yeah.
Yeah.
We'll get there.
Let's see. I don't be wondering.
I was asking for you.
Okay, there you go.
Right.
Good job.
Really, family.
No.
I'm not involved.
Okay.
This is Carrie. Can we take a dig?
Yes.
Happy this.
Thank you guys so much. I appreciate- No, I'm seriously
so
so.
great, like,
Is
I was so pleased to be a candidate. Yeah.
Everyone think about.
I also understand just how difficult your work is.
Like, it was really nice to have the tie-in with the actual data too, like what's actually happening on the ground.
Yeah.
Since we've done this before, but if we've talked about it, it's really nice to have that tie-in. I think this is like, I still feel like this is a good thing for us to build on. There's somewhere like this.
Oh, yeah, and as you said, growing into this the last few years.
Yeah, and people have a lot of interest.
We got a lot.
Yeah, exactly. I mean, as we expand to, PTSD is a really sensible place for us and how people and you and. Can we do the behaviors real quick?
Tentatively say family.
Family photo, please. Sorry, we'll get out of your hair. I was like, oh,
I
we did. Oh, good.
Bookended by dudes. You want me to be on that side?
Okay, say regulation.
He was here. A real time. He, I think he was worried that he was gonna have to speak.
Yeah.
What?
I have to write you to.
We got a funny. In a funny way.
You be around. Yeah. Oh. Thank you guys so much. I'm feeling this a little bit because I got to make you. Yeah.
We're not allowed to take you can help take another one. Where that light is reflecting off my forehead.
Stop.
Yeah, it was nice to meet you. Yeah, again, I feel like I've been hearing about you, like hearing about you for years. Oh, totally, yeah. You look like you're in pain. Yeah, all night. Yeah. No, I'm excited. That's all right. We've never taken a normal food.
I don't want to.
It's strong samples. Make a couple of.
Oh, no. Yeah. Okay, Susan, maybe you please, that's Yeah, so we just got.
Where you going to next?
We're getting like younger than right, since we're in high school.
Good job, Abby.
Thank you.
Excellent.
Thank you. And so one of our partners made this.
I think you're a great conductor.
Thank you so much, but you know what, I've gotten a lot better at it now, it's like 5 minutes, my first conversation. I feel like I should talk about last week. Always.
Yeah, you also.
Like start even that conversation, I was like. oh, there's something.
I mean, that's like AWWAs where.
But yeah, it's sort of that. I had we just found out, like, no, I assume we're going to like. We'll go in the order. We just found out if it's funded, so. No, and trying to get my ducks in a row. Yeah, and yeah, I mean, that's like the biggest issue, right, is like.
From Malawi University of Business and Applied Sciences. Perfect. Okay, so we'll go in the
Yeah,
order.
I mean, maybe it's just like.
So you'll be third. You'll get 15 minutes for your presentation. And then 5 minutes for questions at the end. We'll have our timekeeper is in there with the blue and the yellow shoes. She'll be sitting somewhere in the front row here, and she just has a sign that says 3 minutes remaining, 1 minute remaining, so that you can keep track of the time.
Yeah.
Confirm that that's fine. Yeah, so let's just check.
Oh, hey Darcy, how are you doing?
I'm good, how are you?
Good, I put mine in the front there, I wasn't sure where to put it. It should be sitting in the background.
There's no extra stuff in here. Which one of these is yours?
Mine is a little bit health ability. Because you're sitting in the background, I couldn't just. I'll make sure you don't put it in my folder, you can pull that, that's my flash drive.
Oh, okay.
Yeah.
Okay, so did you drag this to my desk?
No, I wasn't sure where to bring it.
Okay. So let's get yours. Oh, that's your flash drive, okay.
Yeah.
I was like looking for my name. Okay.
I'm sorry.
No, it's just fine. I was up in your business a little bit, but I did not open it.
I need to clean out that folder.
Okay, yes, so we've got. Okay, rose presentation today is. Yeah, for me, we are in wallflower, what is it? Windflower, what room are you?
I'm right.
I think you would be in the wrong room.
Oh, I'm presenting on behalf of Dr. Alain.
Okay.
Yeah. Sorry. Yeah, I'm not Dr. Alain.
Got it. Okay, great. Applications, we are in.
What's that? From IT that was here earlier, like, everything's okay, right? And I was like, I guess so, and then I started and I didn't see him anymore.
There's a folder on the desktop. Okay, so this has been ejected. So this blue one is yours here?
Yeah, that's mine. You were able to move over.
I did copy it.
Okay, the one that's 23, yeah, I'm not sure, yeah.
Yeah. So that one's my first, so I'll just open these.
Yeah.
And Carrie, that's yours, the second adapting. So I need to check those, make sure they are as expected.
Yeah.
Okay, great, those are as expected. Perfect. I'm gonna do it there. Yours are these ones, right?
Did you see tomorrow we're presenting on the RCT findings from our word
I
study?
saw that.
Yeah.
I'll see if I can dip in. Unfortunately, I'm booked for another session, but I'll see if I
I can always
can.
listen to the recording after.
That's true, yeah. Okay, great.
Sit up here, like, I don't know, sometimes they've had people just like.
I would sit in the audience. I think it's self-distracting. I'm great. So if you, I just sit somewhere towards the front. So
The front, to be told what to do.
I'll sit here on this corner and my 10 people probably will sit here, but you're welcome to any of those three. Okay, one second, you're trying either way. It's probably better.
I am different, so.
Maybe the best one.
And it's also good time to go to I think even like we work where we can have myself.
Like I just hear the recording again. Machine can actually record it. They try to mess it up. Yeah, let him say it. I have it.
I'm trying to have space in my life.
You can't hear it anyway. Yeah.
Well, I gotta think it. Did go to Asia. I got one out before the coup.
Oh, perfect timing.
Yeah, good. I've never worked in a highly conflict, like a crime state before. Travel is very.
Were you able to go out into the community though?
He does. So our program is operating in urban areas. We did a little bit of piloting in a very urban setting that was within the designated safe zone.
It's probably like our site in Bukavu, probably similar to that.
Yeah, there's a limited distance you're allowed to go to here in the area store, which. So.
Like that.
Yeah,
Stay in a hotel or do you stay on a compound?
I stayed on the hotel, and the hotels there are fairly, like,
Like you have peacekeepers or there were guns.
yeah.
How long did you go for?
I was there for a little bit more than 2 weeks.
Okay.
Yeah.
I like that. Where else did you go for your so far?
That's been fun so far. We're looking to start up a project in Ethiopia.
It's not going well there right now either.
Yeah, it's, yeah.
Unfortunately.
The tougher thing there is actually or not that complex, but
Oh, you're doing it in partnership with the government, which is ideal for it, but when it comes to them.
yeah, one is
Well, let me try.
it's there's 4 parties involved. There's SIN is co-funding the government.
Oh, it's free.
And then World Vision Ethiopia was important to me. We were getting the 4 parties aligned on.
It's just here. At the conference here. Okay.
No one obviously stepped in and named like attending this.
I'm so excited about our feet. Yours really helped us a lot. Like we just did a cognitive evaluation for cholera in Congo. When we use your model, your framework, I don't know if Ellie told you about that. We use the same structure. Basically, it looks like your tables from a hardware study manuscript from our site. So we started analyzing our data in that same way. It's really valuable.
It's great. I'm not.
Yeah, I'm like, I think
What's good to talk to you? Yeah, good to talk to you.
Let's start the timer.
So. No.
So that you know.
Since they are split the
And then we're one presentation questions. That's what it all like. Yeah. So. And then 14 of them.
Yeah.
There's so many good questions.
The different day, Tuesday was very busy.
I was separate for the doing this time, so eventually I need to know, but I need to like listen to the recording of the.
Good afternoon, everyone. We are just a few minutes past time here, so we're going to get started and let people trickle in as we go. You are in the room Windflower for our presentations on WASH in healthcare facilities. Up first, we have a presentation from Dr. Christine Marie George, presenting on behalf of Dr. Alain Mwishingo from the Université Catholique de Bukavu, presenting on the effects of a water, sanitation, and hygiene program on hand washing with soap among diarrhea patients and caregivers in healthcare facilities in the Democratic Republic of the Congo, a randomized pilot of the Hygiene 7.
Thank you. Good afternoon, everyone, and thank you, Dr. Anderson, for the introduction. My name is Christine Marie George, and I'm a professor at Johns Hopkins. And I'm presenting today on behalf of Dr. Alain Mwishingo, who was not able to attend this year, on a study that he led investigating the effectiveness of a WASH program to increase hand washing with soap in a health facility setting among diarrhea patients and their household members in Eastern Democratic Republic of the Congo. And the study is a collaboration between Catholic University Bukavu, our research team at Johns Hopkins, and the Democratic Republic of the Congo, or DRC, Ministry of Health. And so Dr. Alain Mwishingo is an infectious disease physician and epidemiologist. He is a project coordinator for the Preventative Intervention for Cholera for 7 Days, PICHA 7 program. He's a faculty member in the Center for Tropical Diseases and Global Health at Catholic University Bukavu. And he's the lead author of the manuscript that's been submitted based on this work I'm presenting today. And so the rationale behind our work is that when you have a diarrhea patient that's presenting at a health facility for treatment, their corresponding household members are at a much higher risk of subsequent diarrheal diseases than the general population during the 7-day period after the diarrhea patient is admitted to the health facility. And for cholera, this is 100 times higher. And this is thought to be because of a shared environmental source, such as drinking water and person-to-person transmission. However, despite this high risk, there's very limited intervention for this population. And furthermore, as we know, healthcare facilities are a high-risk environment for transmission of infectious diseases. And often in our context, and probably in the context of many of you that are in the room, the family members of the patients are the ones that are caring for them in the health facility, cleaning the vomit and the feces from the patient, which puts them at very high risk for subsequent diarrheal diseases. However, in a health facility setting, when you're thinking about WASH, it's usually focused on hand washing among the health providers in the health facility and not focusing on the family attendants of the patient. And so this led our research group to develop the preventative intervention for cholera for 7 days. And the acronym is PICHA 7. And it's PICHA for the pictorial WASH module delivered as part of the program. And then the 7 is for the 7-day high risk period for subsequent diarrheal diseases for the household members of the diarrhea patient. And this is a health facility initiated intervention where a health promoter delivers the pictorial WASH module bedside to a diarrhea patient and their accompanying household members on hand washing with soap at stool, vomit, and food-related events, on water treatment through promotion of boiling and chlorine tablets, and then safe water storage in a water vessel with lid and tap. In addition, enabling technologies provided through providing a soapy water bottle, which is a simple water detergent powder in a bottle as a low-cost alternative to bar soap. And so this was provided in a health facility setting, and the objective is to increase hand washing with cleansing agent practices among the family attendants of the diarrhea patients. And so for the larger Picture 7 program, we also go to the home and have 2 home visits where a promoter delivers a pictorial wash module. And we also provide enabling hardware, which includes a hand washing station, which I show here, along with a soapy water bottle, water detergent powder, and a water vessel with a lid and tap for safe water storage. And then the third component is a mobile health program. And the objective here is to reinforce the behavioral recommendations from the in-person visits through sending voice and text messages to the mobile phones of the households that are part of the study. And even in our context in Eastern DRC, this has worked well, with over 80% of households, diarrhea patient households reporting active mobile phone ownership. So this really presents the opportunity to use mobile health as a tool to promote WASH behavior. And so weekly voice and text messages are sent from a physician at a local college treatment center. And we named her Picture 7, Dr. Picture, and named for our intervention. So these are the 3 components of the Picture 7 program. And so for today's presentation, I'll focus on our health facility initiated component, where promoters are delivering a pictorial wash module and providing a soapy water bottle. And so our study site is in Eastern Democratic Republic of the Congo. We're right on the border of Rwanda, right here in South Kivu province, in a city named Bukavu, which is an urban context, a city of over 1 million people. And we work mostly in peri-urban areas, informal settlements. And so as part of the study, we included 27 healthcare facilities in Bukavu. And the study was conducted from March 2020 to November 2021. And this included diarrhea patients and patient attendants, which we define as people who accompany the diarrhea patient to the health facility during the time of treatment. So to evaluate this intervention, we conducted a randomized pilot where we had 2 arms. And so diarrhea patients were randomized to either receive a standard message given by the DRC government to diarrhea patients upon discharge on the use of oral rehydration solution for rehydration, or the same intervention plus our Picture 7 program, our health facility initiated module by a health promoter and the provision of a soapy water bottle. And our objective was to observe whether this module was effective in increasing hand washing with a cleansing agent. And so hand washing practices were assessed through 3-hour structured observation in these 27 healthcare facilities. And we observed hand washing practices at these key times. So feces and vomit related events, as well as food related events. And so now I'm going to go into our results. And so when we observed hand washing with a cleansing agent practice among our standard arm, we found that this was very low. And here we show the definitions of cleansing agents. So bar soap, liquid soap, soapy water, chlorinated water, and hand sanitizer. These are the common cleansing agents in our context. And so when we looked at patient attendance, we found that 16% of patient attendance in the standard arm washed their hands with a cleansing agent during our 3-hour structured observation period at our key time. And this was 14% for diarrhea patients. However, we saw much higher hand washing with a cleansing agent in our Picture 7 arm, which was 40% in each arm. And this result was statistically significant for patient attendance. So we observed significantly higher hand washing with a cleansing agent among patient attendants in our Picture 7 arm compared to the standard arm. Next, we looked at the type of cleansing agents that were commonly used, and we had this stratified by study arm. And you can see that the most common cleansing agent was a soapy water bottle in the Picture 7 arm. And this again was provided as part of the intervention. So this showed that people were using this at food and stool and food related events. And then we looked at the next most common was bar soap, followed by chlorinated water, which is very common at cholera treatment centers, and then liquid soap and hand sanitizer. So in conclusion, We found that the Pitcher 7 program was effective in terms of significantly increasing hand washing with a cleansing agent practices among the diarrhea patient attendants. So these are the individuals caring for the diarrhea patient during the time of illness. In a healthcare facility setting in Eastern Democratic Republic of the Congo. And these findings indicate that this presents a promising intervention approach for healthcare facilities to help to increase hand washing with a cleansing agent practices among patient attendants. And so I wanted to conclude the presentation by mentioning our ongoing randomized control trial, the Pitcher 7 program, which is following 2,320 participants and includes, so patients are randomized based on the day that they come to the health facility. We have over 100 health facilities that were randomized as part of the study to either be in the standard arm, the partner doesn't seem to be working, either the standard arm on oral rehydration solution or the Pitcher 7 arm. And the Pitcher 7 arm had all three components. So our health facility initiated intervention, our home visits, as well as our mobile health module. And we're following households for a period of 12 months. And so this trial started in 2021 and will continue the end of this year. And the outcomes that we're looking at is diarrheal disease among this high-risk population, the household members of diarrhea patients. And we're also looking at the impact of this intervention on childbirth. And this is a sister study to our previous work in Bangladesh, where we showed a similar intervention significantly reduced diarrheal disease among the household members of diarrhea patients and significantly reduced stunting among children less than 2 years of age. And so we'll have the results of this study at the end of the year. And so that concludes the presentation today. And so again, I would like to acknowledge Dr. Alain Mwishingo, who is the lead author of this work and has submitted a publication based on this, as well as my other colleagues at Catholic University, Bukavu, my colleagues at Johns Hopkins, including Kelly Andreas, who's presenting on our mobile health component in another room right now. And also Elizabeth Thomas, who led a lot of the formative research that went into the development of the Pitcher 7 program, as well as our partners at the Ministry of Health. And so this is our study team. And so this gives you a sense of our context. We're on the beautiful Lake Kivu. You can see that in the background. And so now I'd like to open the floor for any questions and to list up here Dr. Alain Mwishingo's contact information if you wanted to reach out to him. Thank you. Further questions? Yep.
Thanks so much for the presentation. Fred is my name, and maybe back to the study site, Uganda. I'd like to understand what have been the determinants of the choice of the countries in Nigeria.
Yeah, that's a great question. So we conducted 18 months of community-centered formative research to develop the Pitcher 7 program. And this included semi-structured interviews with diarrhea patients, the family members of diarrhea patients, health providers, and programmatic launch stakeholders. And this allowed us to tailor the Pitcher 7 program to the facilitators and barriers of our targeted WASH behaviors. And so the community engagement throughout the process was crucial to ensure that the intervention was tailored to the needs of the community.
I came in a bit later, but in terms of the hand washing type of soap, I see you have soapy bottle and soap water.
Yeah, so we had,
What's the difference between the two?
yeah, so there were several types of cleansing agents. So there was soapy water, which is water and detergent powder. There was bar soap, there was liquid soap, there was hand sanitizer, and there was chlorinated water. And so these were the type of cleansing agents that were commonly used in health facilities in our context. In our intervention, we were promoting soapy water, which is water and detergent powder. Mm-hmm.
Yeah, I think you mentioned that you have done another study similar to this in Bangladesh.
Mm-hmm.
So how compare this study with the one in Bangladesh? Are you able to see some context, specific differences between these two areas? Or
That's a great question. So in terms of our randomized control trial we did in Bangladesh, that was a sister to this, we had very similar findings in terms of significantly higher hand washing soap for delivery of the Chobi 7 module, which is a cholera hospital-based intervention for 7 days among patient attendants that received the Chobi 7 intervention compared to the standard arm. In terms of the contact is completely different. So one of the major differences is water scarcity. And so in our study setting, Eastern DRC, water scarcity is a major challenge. during the dry season. A lot of times households may go days without being able to get additional water from their water sources. In addition, we work in a setting that's had protracted conflict and has much higher food insecurity, and financial insecurity. And so availability of soap is much lower. In our Bangladesh context, we were promoting detergent powder and water for soapy water once households went home. But we realized very quickly in our Congo context that that was not realistic. First, people were not using detergent powder in their home. They were using bar soap to wash their clothes and for bathing. And also households didn't have the financial means to go out and buy detergent powder. And so instead of promoting water detergent powder in the home, we promote water and small leftover pieces of bar soap. So those very tiny pieces that are left after using the bar soap and mixing that with water. And that's worked a lot better. So there were a lot of differences between the two settings, and that's why the formative research is so important to be able to tailor the intervention to your context.
This is a segue from that. I'm curious, could you tell us a little bit more about what your formative research looked like within the community to design this work?
Yeah, so we went to health facilities. We have, right now, I think we're at 124 health facilities that are part of our surveillance system in partnership with the government of Bangladesh. So we went to health facilities and we interviewed diarrhea patients and their household members in a health facility setting, also went to the homes of the patients. We interviewed the health providers and also programmatic watch stakeholders, both within the Ministry of Health as well as development organizations that were implementing projects. That way we can get a sense of the full picture of activities that were going on related to WASH and healthcare facilities in our context. We conducted a pilot as well of 527 participants before we conducted our larger randomized control trial to ensure that the uptake of the intervention was high before putting resources into conducting a larger randomized control trial. And we think that's really important because we conducted pilots previously of interventions that the uptake was never high. So rather than invest a lot of money in a trial that's going to fail, we move on to something else. So those are the steps we took for our formative research. Are there other questions?
Yes, I'm called Matthew Wasis from Uganda. I was wondering, sorry for the labeling, the diarrhea patients, in case is this consistent or there are peak seasons, outbreaks, and because it's not like a long-term illness. So I'm just wondering how were you able to follow up?
So that's an excellent question. So in our study context in Eastern DRC, Bukavu, it's a bimodal peak. So we have a spring peak and a fall peak of viral disease. In particular, they align, the highest number of cases are aligning when you have the cholera outbreaks. The cholera outbreaks are commonly occurring in the spring and then in the fall in our context, and that's when the diarrhea patient volume is the highest. Are there other questions? Yeah.
Rain and dry season.
Yeah, the rainy season and the dry season. So both seasons.
Yeah, thanks for the presentation. I was just wondering the feasibility of this intervention, most especially the home visits and the texts and phone calls. In the normal day-to-day life, what I understand about the DRC, how feasible is that? How feasible is a medical practitioner able to make the visit or ring up individual patients?
So that's a great question. So these are not medical physicians. We have health promoters that deliver the intervention initially in the health facility, and then community health workers that were delivering the 2 visits in the home. And ideally, taking this intervention to scale, there's community health workers already embedded in the community in our context. And so we could potentially add this to their many responsibilities. That could be one approach. For the mobile health component, we did a lot of formative research around this in our context. And around 80% of households in the peri-urban area where we work, which is mostly informal settlements, reported active mobile phone ownership. So this is an approach that can be delivered to the majority of the population. These are pre-recorded calls. So Dr. Pitcha, a physician from a local cholera treatment center, is sending pre-recorded calls to diarrhea patient households, reminding them to practice the key WASH behaviors. And then we send out text messages. So there's always a call and then it's supplemented by a summary text message. We've seen really high uptake with this, both in our pilot and our randomized control trial. And I had mentioned in another room simultaneously, we have another presentation that's going through that. But we're happy to share our publication on this work, where we did formative research around the mobile health component. Thank you for your question. Are there other questions? Okay, thank you so much for your time.
Great, thank you, Dr. George. Up next, we have Carrie Ripkey from the CDC Foundation presenting on adapting WASH interventions for primary healthcare facilities in Uganda, a participatory design approach.
Oh, good afternoon, everyone. My name is Carrie Ripkey, and as Darcy said, I am a WASH advisor with the CDC Foundation, working alongside the global WASH team at the U.S. Centers for Disease Control and Prevention of CDC. So today I am privileged to present on behalf of several wonderful colleagues, some of whom are in this room today, colleagues from the Infectious Diseases Institute of Uganda. Fred, raise your hand. Colleagues from IRC, Martin is filming, we're taking photos, as well as colleagues from the CDC and the local government. So today I'll be sharing on behalf of our collaborative work together that's working to adapt WASH interventions for primary healthcare facilities in Uganda using some participatory design approaches. So the work of this project is built upon existing collaborative partnerships within this district. So that's Kabarole district, which is located in Western Uganda, near the border of DRC. And so these collaborative partnerships in Uganda and other locations in healthcare facilities and other locations such as points of entry, markets, etc., have informed sort of the design and drive of this work. So as part of our collaborative work together, we've had the opportunity to collect data several times. Some folks in this room have been part of that data collection. So we've been able to see that from 2018 to 2022, public healthcare facilities in Kabarole district have moved up the JMP service ladders in many domains, but today we'll be focusing on the areas of hand hygiene. So that's this one in purple here. That's middle for environmental cleaning, and then finally for water. So you'll see here for some domains such as hand hygiene in purple here, facilities have greatly increased their coverage of basic hand hygiene services, while others such as environmental cleaning have not yet had any facilities that hit basic service levels, but we do see a reduction in facilities with no service. So we celebrate those improvements. Similarly for water. But for those of you that are familiar with the JMP services and standards, a lot of these are about policies or infrastructure. And even if you're not an avid behavior change person, I think we all can agree on that infrastructure alone is often not enough to promote behavior change. So as we saw these service levels rising, the question that we found ourselves asking is how can we ensure that the actual practices in these domains, so within hand hygiene, ensuring that hand hygiene is taking place at the appropriate times and in the appropriate ways. Within environmental cleaning, ensuring again that environmental cleaning is taking place with the right resources and supplies at the right times and in the right frequencies. And then within water, ensuring that there's a consistent supply of safe drinking water available for healthcare workers and patients and their attendants, which we'll hear about more today. So armed with that question, we engaged in a small pilot project, which feels very small now after hearing the size of your project. So again, these priority areas of domains of hand hygiene, environmental cleaning, and water point operation and maintenance were informed by some of the work that our team had already done in the area. So we had the privilege of collaborating and conducting some wash bed assessments to better understand where there may be gaps in the enabling environment for these appropriate wash and infection prevention control behaviors to take place. So again, sort of the objective of this work then was to evaluate if the proposed solutions that we are going to come up with collaboratively, which I'll dive into later, would actually increase the uptake of water, sanitation, and hygiene, or WASH, practices, and then sustain the management of these services in a way that would both meet the needs of patients and healthcare workers within facilities. So we had a very, very small pilot. So our first set of facilities are 5 health center 3s located within Cabarrola district. They are all public facilities that provide basic preventative and promotive care, as well as some basic obstetric care. And when we selected those, as we knew that there's strong institutional buy-in and support for participating in WASH interventions, as they were already selected to serve as models for WASH and healthcare facilities in the district. So how did we do our work? So the approach that we took closely mirrors the ADAPT-IT model, which is put forth by Wingood and DiClemente in their work, but for today's purposes, I'm going to just phrase it as 4 different phases of designing, testing, revising, and expanding. So within the design phase, let's see if this guy is working. Okay, yes. So our design phase here, we first undertook not a very formal literature review, but a review of both peer literature and peer-reviewed literature, as well as reaching out to colleagues in the field, asking for their suggestions of best practices that they've seen, and then reviewed those. Then we brought forth those ideas to an intervention co-design workshop, which we'll dive into later, and then sought additional input on these ideas that sort of emerged from additional facility actors. Then the next phase was testing of the interventions. So this started with training of key facility personnel, such as infection prevention and control focal persons, environmental cleaning staff, and the in charge or the facility director. So as part of this phase, we had built in several planned opportunities for data collection and feedback, the first of which took place in August 2023 and was exclusively qualitative and designed to get feedback on the acceptability of interventions and perceived changes. So then what are we going to do with that data? What's the point of collecting that? Then our goal is to revise the intervention components armed with what we have learned from this qualitative data collection, as well as some informal feedback that we've received from participants as well. Then once we've had the opportunity to revise, we hope to expand to additional facilities. In the next month, we should be expanding to 5 additional facilities and hopefully can make the case for additional funding and further expansion. So our presentation today is just going to talk about the first 3 phases that we have going on here of design, testing, and revising. So the promising approaches that we identified in the literature review served as the starting point for intervention design. Within hand hygiene, some of the ideas that rose to the top from our review, both of interventions, both in healthcare facilities in similar contexts or high income contexts that we thought we would be able to adapt, was use of the WHO's hand hygiene self-assessment framework, the CDC hand hygiene observation tool, as well as the idea of hand hygiene competitions. Then within environmental cleaning, the Teach Clean package, which I don't remember how it's been rebranded, but the Teach Clean practice package, as well as best practices for environmental cleaning in healthcare facilities in resource limited settings, as well as the accompanying program improvement toolkit. Then within water point operation and maintenance, the idea of using standard operating procedures from other contexts such as schools emerged as a promising approach that had worked elsewhere. Equipped with these promising approaches, we were then able to convene a 2-day intervention co-design workshop, which brought together, again, over 25 attendees from the district health office, individual healthcare facilities, as well as the Ministry of Health, with the goals of both sharing what we had found through literature review, as well as learning from participants about the current approaches to management of WASH and healthcare facilities in these key project areas, and then to work collaboratively to develop solutions that would address the needs of patients and staff in these primary healthcare facilities in the district. So we had a general sort of flow or cycle that we would go through within each of these domains, starting out with discussing current experiences that facilities were experiencing, what was working, what wasn't working, what ideas that they wanted to try. again, that leads into this idea of sharing promising approaches and then brainstorming appropriate solutions. And then some of my colleagues who are very skilled at facilitation and consensus building then walked us through some exercises for us to then select which ideas we wanted to bring forward further for design. So what ideas emerged within the hand hygiene domain? Participants were really excited about hand hygiene competitions between facilities and liked the idea of using patients as observers for hand hygiene. Then within environmental cleaning, facilities were interested in developing SOPs for environmental cleaning and key activities using existing IPC and Washington Healthcare Facilities guidelines that Uganda already had in place, but they were just large textbooky type things that weren't easy to utilize. And they were also interested in the idea of using a checklist that could be posted in key wards or areas to monitor cleaning practices. Then within water point operation and maintenance, we had originally thought we'd be focusing on piped water connections, but really this idea of rainwater harvesting tanks as having greater need emerged. So that started to be a theme that emerged there. And there was also an excitement to attempt the circuit rider approach, which some of you may have heard about in other sessions, using a local group, which is the Cavalry Hand Pump Mechanics Association. So I mentioned that there were only about 25 folks at this facility, and there are many more than 25 healthcare workers or patients attending these facilities. So we thought it would be important as part of our baseline work to solicit additional input from other users that would be impacted by these interventions or be required to use these interventions, both to learn about the state of the healthcare facilities as well as would these be acceptable to them. So that's my segue into talking about the idea of acceptability was a key core component of the work that we did. And so we leveraged the theoretical framework for acceptability, which was developed by Sikon and colleagues. And so there are 7 domains here. We focused really on the domains of effective attitude, which is how an individual feels about taking part in an intervention, as well as perceived effectiveness, which is someone's the extent to which they think the intervention is likely to achieve its purposes. There's also an aspect of temporality here that we're considering about. So we have the idea of prospective, concurrent, or retrospective acceptability. And since we were asking about this before the intervention is in place, we considered this a measure of prospective acceptability. So to round out those perspectives, we conducted in-depth interviews with one healthcare worker per facility, one environmental cleaning staff member per facility, as well as conducting focus group discussions with about 6 to 10 patients or caregivers at each facility. So I'm going to quickly run through some of our findings within acceptability. So overall, effective attitudes were generally positive within each of these interventions that I've explained, but also revealed key concerns about suggested approaches. So for example, the idea of using patients as observers, from one of the focus group discussions, someone shared that some of us are receiving ARBs or antiretroviral therapies, and there are nurses who spread our information into the community. It's hard to remind the worker because they may spread our health status to the community. One time I wanted to confront a healthcare worker and caution her integrity and ethics, but someone told me to ignore this. That was one outlier in terms of effective attitude. Then in terms of perceived effectiveness, again, across all 3 intervention components, this was high across users and intervention components. So an exemplary quote here is that environmental cleaning checklists are very useful because they help us to look at where the strength is, to look at where our areas are, where we need to improve, to look at maybe where we need to do better. So based on the results from these qualitative interviews and focus group discussions, as well as hand hygiene observations, environmental cleaning observations, facility surveys, and knowledge, attitude, and practice surveys, we made some modifications to the proposed interventions based on the ideas that had emerged to better tailor them to the context and to better meet some of the gaps of the enabling environment that had emerged. So within the hand hygiene domain, we received the feedback or came to the conclusion that we also needed to ensure the provision of adequate supplies to perform hand hygiene, such as additional ABHR, and incorporate some additional managed messaging channels for behavior change. So we made t-shirts. Then within environmental cleaning, we need to ensure the provision of adequate supplies to perform environmental cleaning tasks. So providing aprons and gumboots and things that would help environmental cleaning staff feel safe in their role. Then within our work, we had a focus on decided to then indeed focus on rainwater harvesting rather than piped water connections, as this is where there's greater need, as revealed by later water quality testing, where we are struggling with the water quality from our rainwater harvesting tanks. So hopefully Fred will be presenting on that next year. So where are we now? So intervention testing is continuing and will continue to provide opportunities for feedback and revision. So as intervention components have been rolled out, there have been interactive trainings that we've been able to put on, as well as opportunities for, again, follow-up interviews with this information used to revise our approaches. So trying to wrap up quickly here. One of our key takeaways here is that this participatory design approach generated intervention approaches that have high prospective acceptability and tentatively from our preliminary analysis, concurrent acceptability as well. We see that the continued opportunity for end users to provide feedback both formally in interviews as well as informally through supportive supervision has generated useful information and helped us design intervention components that have high acceptability. So again, as I said, we are limited to a very small sample size, so the findings from this work are not generalizable, but we hope that we can expand our work. So moving forward, we will have some additional data collection, additional revision of our intervention component, expansion to additional facilities, an end-line assessment, and then hopefully dissemination of findings and lessons learned. So with that, I will leave you to read my acknowledgements, many again of whom are in this room today. And so thank you all for your time. Any questions? We need to pass a microphone. I don't remember.
So this room has integrated mics.
Wow, it's a fancy room. Okay.
What part of Uganda are you working in?
Yeah, so we are in Western Uganda. Sorry, this is my mental map. So Western Uganda, not right on the border with DRC. We have one district between us and DRC. This is Cabarole district.
Would you be interested in having a nurse that is also a well driller from Eastern Uganda get in touch with her?
Yes, I believe so. We
Okay.
are interested. So Fred and Martin are my two more local colleagues back there representing the row there. So they would be the best folks to talk to, but we are always excited to bring more people in and learn more. So we'll talk afterwards. My apologies, our other colleague in that row.
Yeah, thank you for that wonderful presentation. Don't you think the use of patients as observers for the healthcare workers kind of like, messed up with their results? Because I believe you did anticipate that, these patients would withdraw from actually, approaching these healthcare workers, because there can be concern that, they may share their sensitive health information with the community. Don't you think it's kind of like?
Yeah, so that was our concern. We didn't actually ever implement that process. Our dear friend Fred here was actually one of our wonderful hand hygiene observers. So hopefully no adverse effects to him, but because of that concern, we didn't move forward with using patients as observers. We've seen ways that this has been done in the US in what have been labeled as low resource settings in literature with no adverse effects to patients, but given sort of the goal of this project again was to design interventions that were acceptable to everyone involved. And so we heard that feedback that this was not acceptable to patients. We did not move forward with that. I don't know if I understood your question well. So if there's
Yeah, sure. And my final question would be, much of the rainwater that you like harvest from the rooftop, those tanks are usually like kind of like contaminated. So how do you ensure that you still achieve an hygiene using that same
Well, this is a great question, and we are still continuing to explore what the best options for this. So we are putting forth standard operating procedures for operation and maintenance. But again, we found that while most of the facilities that we're working in, and again, generally in the district, most facilities have piped water connections, but with water cutoffs or with issues with seasonality, that these rainwater harvesting tanks are being used for drinking water. And so we are trying to figure out what is the most feasible way to treat this drinking water. So we've been trying to have lots of conversations this week with what it will be a low cost, because facilities already don't have enough in their budget for wash and healthcare facilities. Come to our event on Thursday. Yep, Thursday afternoon to hear more about that. So yes, water quality in those rainwater harvesting tanks is not currently great. And we are actively thinking about what are the best solutions that are feasible to implement there. And Fred will be presenting on more on that at the Conference on Public Health in Africa at the end of November. So if that's near you, go attend that and hear more. Yes.
Yeah, I have two questions. One is on the objective of the study. I just wonder why you use the word uptake instead of access or use. Is there any specific reason for that? And then my second question has to do with the environmental workers in the healthcare facilities. Whether your interaction with them, what you got from them in terms of ways to improve the facilities that you have in those parts.
Yeah. It was a very long time ago that we wrote the specific objectives. So also if Victoria has any more insight, she's was another architect of this work. In this exact moment, I'm feeling as though the use of the word uptake was selected because I think that again, from a lot of our CAP surveys that we've been able to do, there's a lot of knowledge that's already there. We're increasingly having the appropriate infrastructure. And so it's people putting into practice what they already know. So uptake felt appropriate, but there's probably a better answer than that. So your second part was related to environmental cleaning staff. Could you say more?
Yeah. I was just saying whether you got some information or insight from the work that they do in these facilities that will inform either the use or the uptake or the sustainability.
Yeah, I don't know, Fred, I know that you have worked very closely with the environmental cleaning staff and been addressing some of their concerns. I don't know if there are any salient points to you or things that were surprising to you.
Thanks so much for that question. And again, getting back to the use of the word uptake, as you mentioned during the background, but there have been some kind of interventions in this district, but still we see, the three domains not really getting up about 50% of cleaning. So we're like, now, what can we use a human-centered approach to increase this up? So that's why I say uptake with intervention.
Okay, I brought that up because of the technicalities regarding the use of water access.
Yeah.
And then use of it. So where does it fit with? Because you reference JMP and then you talk about access and use, so that's why, and uptake is not really, that's why I sort of wanted to know a bit more.
Okay, exactly. So regarding the healthcare and the healthcare facility cleaners, we have a challenge in terms of having the package for these people who are employed to go and clean these healthcare facilities. So they don't have adequate knowledge. Sometimes you find somebody who has not completed senior 4. I don't know how it is here in the US. Level 4 is hired as a cleaner, but without adequate knowledge about the environment within the healthcare facility. So what we did is to use the available resources, both some kind of training materials, including information on waste management, cleaning and disinfection, and then PPE, the personal protective equipment. So those were the main concerns that came up. So for us, they had needed some supplies like chlorine for disinfection. They never knew how to utilize it. They require that kind of information to really.
So I think that also goes with the idea of
myself, I'm David Church. I work for Catholic Relief Services.
Wonderful.
And we have some programs in Uganda. I'm the global head for water supply. So that's why I just introduced.
Yeah, no, and I think that really shaped the work that we did of, we went in with the idea of, that we knew that policies and procedures existed in Uganda, but like I said, sat in Martin's office and looked through them. They're giant booklets and those aren't very accessible, particularly to folks with low literacy. So our conversations with health, environmental cleaning staff confirmed that they wanted things that were easy to read and understand, so very pictorial in nature. The Teach Clean package has several like pre-existing graphics, and so we tried to lean on those and tweak them a little bit to better fit this context, to again make them accessible. But like I mentioned before, I think again one of those key enabling factors to practicing like the appropriate procedures was having that PPE to feel more confident to go into the situation. So while that wasn't originally planned, that was part of improving the enabling environment so that they could be successful in doing what they learned. So thank you so much.
Great, thank you. I think I saw there were a few more hands in the audience. Carrie, I'm going to volunteer you to speak to people after the session if you would like to come up to the front. Great, thank you. Our last presenter of the day, we have Ms. Mindy Panulo from the Malawi University of Business and Applied Sciences, presenting on assessment of infrastructure, behaviors, and user satisfaction of guardian waiting shelters at Southern Malawi hospitals.
All right, good afternoon, everyone. As already introduced, my name is Mindy Panulo, and I'm a research associate with Washington Center, which is under Malawi University of Business and Applied Sciences. And today I'm going to take you through a presentation titled Assessment of Infrastructure, Behaviors, and User Satisfaction of Guardian Waiting Shelters in Malawi. So due to the low healthcare worker to patient ratio in Malawi, hospitals rely on using family members to act as patient carers, sometimes known as guardian patients, in order to provide nursing care. So they are there to offer basic nursing care. I know in some settings, basic nursing care is offered by healthcare workers, but because of this low shortage of healthcare workers, these family members are there now to provide the basic nursing care. So in this circumstance, there's a reason why the family members need to be available within the hospital premise. So in this case, these guardians stay within the hospital premise in dormitory type of accommodation, which are usually known as guardian waiting shelters in the Malawian context. In some cases, these waiting shelters have also been found to also provide accommodation to maternity waiting mothers. As already know that WHO promotes maternal child health through the provision of maternity waiting homes in developing countries' healthcare facilities. But in some cases, these waiting or these hospitals don't have a formal maternity waiting home, which results in the guardian waiting shelters now providing shelter to the maternity waiting mothers. An example of these waiting shelters is the picture you are able to see here. This is a setting of a guardian waiting shelter where guardians use this to cook, wash their linen, and also even to sleep in. So this is like a formal waiting shelter in the Malawian context. Despite the role of these waiting shelters, previous research in Malawi has only focused on maternity waiting homes and not guardian waiting shelters. Thus, the aim of our study was trying to understand the current infrastructure needs and the conditions of these infrastructures in the guardian waiting shelters, and trying to understand the daily life in the waiting shelters, as well as trying to understand how satisfied are the users in these waiting shelters. So the study was conducted in the southern region of Malawi in 12 waiting shelters, of which 10 of these were serving public-owned healthcare facilities, and 2 of these were serving private-owned healthcare facilities, usually which were belonging to a second tier of hospitals according to the healthcare system in Malawi. So we used a mixed method approach, and the target audience were like people like the representatives from the Health Advisory Committee, the Hospital Management Committee representatives, the guardian waiting shelter caretaker, most importantly, the patients themselves, and also their chairperson. So I'll just give you an overview of who these target audiences are, just for you to have an idea. For example, the hospital advisory committee, it is a committee that is set at the hospital level, which includes representatives from the health care workers and also members from the communities. So this committee is just there to act as a bridge between the health care workers and the community members in case they have any disputes. While as a waiting shelter caretaker is someone who is usually employed by the hospital to take care of the waiting shelter on a daily basis, making sure that it is clean. While as a chairperson is a guardian, a patient guardian rather, but in this case, this guardian is selected by other guardians to act as their leader as they're staying at the waiting shelter, just making sure that there is order in the waiting shelter. As I already mentioned, that it is like their home, so there was supposed to be order in these settings. So for us to achieve our aim, we used observation checklist, and this observation checklist allowed us to assess absence or presence of infrastructure. For example, sanitation facilities, water points, kitchen, or even sleeping areas. So we are trying to use this observation checklist to understand if they're available, and if they're available, what are the conditions of these infrastructures. For us to understand the daily living of the users in the waiting shelters and how these waiting shelters are managed, we then did interviews and also focus group discussions. So on overall, we had a total population of 249 respondents, of which 221 were the guardians themselves. So we got more information from the guardians themselves, understanding how much at the waiting shelter. Not surprisingly enough, most of these guardians were women who reported to say, I'm here because I'm taking care of my relative or my daughter who is waiting to give birth. So on overall, we found that on average, these waiting shelters were serving across or up to 100 people in a day. So 100 people will be in a waiting shelter, either using it for sleeping or cooking or doing other activities. And on average, one would stay at a waiting shelter for close to 3 weeks. So you're away from home, you're taking care of a patient who is sick, and you're staying there for 3 weeks. Just an overall comparison between waiting shelters that were serving public-owned and those that were serving private-owned healthcare facilities. We found that those that were serving private-owned healthcare facilities were much better because we are fully supported. So you find that they had some amenities that were not present in those that were serving public-owned healthcare facilities. So we found that from the 12 garden waiting shelters, 4 of them had a caretaker, someone who was employed to say, today I'm going to clean this, today I'm going to do this. And when you just try to compare the presence of a caretaker in the waiting shelter and the waiting shelter that does not have a caretaker, the conditions were better off in cases where there was a caretaker. And in one private-owned or garden waiting shelter that was serving private-owned healthcare facility had a security guard. So in the rest others, they did not have a security guard. And to make things worse, in 2 garden waiting shelters that were serving private-owned healthcare facilities had electricity. So the rest did not have electricity. One important thing that we noticed was the presence of, in some waiting shelters, they were collecting money from the guardians. So this money was being used for their welfare while at the waiting shelter. And we found that this money was used for buying cleaning materials like brooms, brushes, and mops, and sometimes even buying lighting materials, for example, candles and torches, just to use for that at the waiting shelters. In 10 of the waiting shelters, we found that they had a kitchen where they were able to provide meals for to prepare meals for their patients. However, the guardians reported that these kitchens were not adequate enough to accommodate everyone. And in some cases, these kitchens had poor ventilation, considering that the primary source of fuel that they were using was firewood. So because everyone is cooking and they're using firewood, they were mostly found to be or to lack proper ventilation. Most importantly, we found that 7 of the waiting shelters had a functional sleeping rooms that were using to sleep in. In cases where a waiting shelter did not have functional sleeping rooms, the guardians reported to say they were sleeping in the hospital corridors. sometimes even just beside their patient in the hospitals. And in those that at least had a sleeping room, the complaints were that these accommodations had or lacked security because the doors were not lockable, the windows were broken, there was no electricity, no guard, even worse, they were always cut. For example, about 3 people were sleeping in a square meter, which made the rooms uninhabitable. We did a further investigation, just trying to understand the wash characteristics within the waiting shelters, and we found that at least half of the waiting shelters had access to water supply within the waiting shelters. However, these water points had issues to say sometimes the taps were broken. So in case of the taps were broken, the guardians were still forced to use the water points. As you can see on the bottom left, that picture, the tap is broken, but guardians are still using that to fetch water for their daily use. And sometimes even the water points were very unhygienic. The reason behind was that most of these waiting shelters did not have like a formal place where they're supposed to clean their kitchen utensils or even just to do laundry. So these the guardians were forced to use the same water point to do those activities, which resulted in making the water points very unhygienic. And in places where they reported that they did not have water within the waiting shelter, they reported that they would go to the hospital to fetch water, sometimes to the nearby communities, markets, and schools, just for them to fetch water. And it was noted that sometimes it's water we were supposed to pay just for them to access the water. Pertaining sanitation, we found that at least 7 of the waiting shelters had sanitation facilities. However, in waiting shelters that were serving public-owned healthcare facilities, their sanitation conditions were very poor because most of the toilets were full. Sometimes you will even find indiscriminate disposal of feces on the floors. And as you already know that this already can bring disgust to a person. So the guidance even reported to say, I cannot use such a latrine or toilet. So instead, I would sometimes go to use a bathroom as a latrine, or sometimes I'll opt to practice open defecation, which was really evident in 3 of the waiting shelters, where we found that some guardians were practicing open defecation. Hygienic-wise, majority of the waiting shelters had a bathroom. Although these bathrooms had issues, one, they had issues of lack of doors, which led to lack of privacy in these bathrooms. And most importantly, that some of the issues was poor drainage and even presence of menstrual hygiene materials in the bathrooms, which led to most of these bathrooms being very unhygienic. So you'd go to a bathroom, you find that the nappies there are pampers, which made most of these bathrooms very unhygienic. And issues of poor hygiene was also observed and reported from the guardians themselves, as this was evident to say in only 2 of the waiting shelters, we found handwashing facilities. From the rest, we did not find any. And although we found these waiting shelters having handwashing facilities, these handwashing facilities were not of standard, and we did not even find soap in either of these washing facilities, which really affected the hygiene practices in this setting. As I already mentioned, some of the issues was lack of an allocated place where they're supposed to do their laundry, which resulted in the guardians using the water point to clean the soiled linen even after someone has given birth. So they'll do that, which affected the hygiene in the waiting shelters. Pertaining management, we found that in all of the waiting shelters that were serving public-owned healthcare workers, there was no clear ownership to say who owns this waiting shelter. So you go to a facility and you ask how do you manage, or who owns this waiting shelter? The hospital will say it's the duty or the responsibility of a district council. We go to a district council that say, no, it belongs to the community. So there's that lack of ownership and responsibility in those wedding shelters, which really resulted in making the wedding shelters neglectable areas, which was evidenced by there was lack of allocation of someone to take care of the wedding shelters. Even worse, just allocating money to say on daily basis, we are allocating this money for this to enable daily management or running of the wedding shelter, which really resulted in making the wedding shelters a neglected place. Most importantly, in neither of the 12 wedding shelters did we find policy. So there are no policies or guidances to say we have this thing with us. How do we manage them? How do we use these wedding shelters? So we found that there is no policies, and as we try to compare that with the wedding shelters, maternity wedding shelters rather, a maternity wedding shelter would always have policies and guidance to say a standard maternity wedding shelter should have these. But when you try to compare that with the garden wedding shelters, there is none, which really resulted in making these wedding shelters a neglected place. As much as the guardians themselves appreciated to say, okay, I'm here to take care of my patient. I have somewhere I can cook, I can sleep. But they really complained to say, we are living in conditions that are not favorable, which affects our daily living. Someone would say, when I'm home, I'm able to practice food hygiene because at least I have a dish rack where I can keep my kitchen utensils. I have a tippy tap where I can wash my hands. But in this setting, we lack those infrastructures which can enable us to continue the various wash behaviors which we wish would have. So we found that these areas, as much as they play a significant role in the utilization of the healthcare facilities, but there is that lack of ownership which has resulted in making these wedding shelters very neglectable. And this does not only affect the dignity, the privacy, the security of the mothers, but it also does leave them at a risk because they're exposed to the various environmental exposures. For example, they would even say, we are living in crowded rooms, we are prone to have or to get TB or even COVID-19, and they'll say the kitchen is not good, the bathroom is not okay, the toilets are not good, we are prone to diarrhea and cholera. So these are some of the issues that the guardians really reported to say, yes, we have these wedding shelters, but we wished the conditions were improved. So yeah, just appreciating to say we have these guardians who are really helpful in making sure that these healthcare facilities are being utilized. But then in what condition are we leaving these guardians? Apart from making sure that we promote their dignity, their privacy, but there's this risk of transmission of disease. There's a risk of transmitting disease within themselves as guardians, even transmitting the diseases to their patients in the wards, even worse, transmitting the diseases to the entire community when they return home. Hence, it is really important that as much as we are trying to utilize these guardians, we need to make sure that these guardian waiting shelters are of good standards. And as we're still striving to achieve SDG number 6 come 2030, are we only focusing on households only, or are we focusing on both institutions and also households, which is really important for us to focus on if we are to achieve SDG number 6. It is very important to make sure that these wedding shelters have clear management standards, policies, and make sure that we have sustainable long-term solution to say how best are we going to improve these wedding shelters so as we make sure that they're in good state, promote the utilization of healthcare facilities, and make sure that come 2030, we are able to achieve sustainable development goal number 6. So yeah, so I've just given a tip of an iceberg, and I urge you, if you have time, to go through the policy brief, which can be found using the link, and even more, you can be on the look to have a look on the preprint, which will be available by the end of this week. So lastly, I'd like to thank our funder, RGHI, for funding this research, and most importantly, thanks to all the investigators from London School of Hygiene and Tropical Medicine, from University of Strathclyde, as well as from Washington Center at Malawi University of Business and Applied Sciences. Thank you.
Hey, Victoria Nace from CDC. I thanks so much for that great presentation. This is an entirely new area for me, and it is something that really needs to have some light shed on it and some attention. I'm curious what at the national MOH level, what their perception of these shelters are. Are they official? Are they recognized? It's, really widespread. Are they? Yeah, just like what does the national level MOH think about them or talk about them, and have these results been communicated afterwards, and have there been any kind of like dialogue around action?
All right, yeah, thank you for that good question. So yeah, these waiting shelters are nationally recognized by the Ministry of Health. They really know that we have these waiting shelters in our hospitals. The only problem is that lack of ownership or policies to make sure that this is really functioning. For example, there was a time we had a chat with one of the management members, and he was like, I remember when I started working in the healthcare setting, there were policies. That is like 20 years ago, but I don't think those policies still exist. I'll look for them, but I don't think I can find them. So they have, or they appreciate, or they know that we have these waiting shelters, but I think it's just that lack of ownership to make sure that these waiting shelters are really serving their purpose. And to answer your question concerning if they know the results, yes, they do. We shared with them the policy brief, which we feel like it would be helpful to make sure that things get better soon. So yeah, thank you.
Thank you. My name is David, and I'm Washington, Kenya. I think one of the things that you've answered, I was looking at what you explained about ownership and wondering, someone might have put those, guardian shelters in place. It could be maybe the state of policy, and they are no longer maybe supported by the government. Then that could be one of the things that maybe you may want to let us know whether there's been change in policy, because someone put them in place, but now nobody wants to own them in terms of providing the work infrastructure. Otherwise, if they were not necessary, and have been demolished. So the other thing that really I really could be used as scope, but did you find any similarities in terms of washing infrastructure in the healthcare facilities themselves? Maybe mirroring what is the guardian shelter, or was they better than what was the guardian shelter in terms of
All right, thank you so much. I think I'll start by answering the first one. So the policies are there and they haven't changed. As I earlier mentioned, to say this policy, it was developed ages ago. It's only that it hasn't been updated, and no one even thinks about it. I think it's like business as usual to them. And I think one of the issues that we noted could be a contributing factor to this problem is that lack of involving or thinking about a waiting shelter when people are building a hospital. In some instances, we would find that they have built a hospital without considering a waiting shelter. So a donor would come at the waiting shelter, of which sometimes the government or maybe the management will be like, it doesn't belong to us. So there are those things that may have contributed to this lack of negligence, which has really resulted in making these waiting shelters in a neglected area. And for the second one, for the similarities in the presence of infrastructure between the hospital and the waiting shelters, the hospitals did have, although it wasn't our focus, but the hospitals did have infrastructure. And I didn't mention to say that this study was conducted in 2021, 2022, where COVID was still a problem. But we see that despite COVID being there, issues like hand hygiene wasn't even being considered. So it's like something that is in the system, but it's sort of being neglected to say, I think this is not part of us. I think we're just concentrating on the patients themselves and not their guidance. So, yeah.
That will be an ongoing one, and we work together with Mindy. Just want to add to the patient that we share with responding. You see that at administrative level, there is a well-placed infection prevention and control program in place. But this IPC mainly focuses in the health care facility, the hospital itself, but it doesn't look at the guardian waiting shelter. Because the Ministry of Health is not looking at the guardian waiting shelter as part of its responsibility. So there's really a lack of the focal point. As she has said, sometimes it is constated by the politicians when they are campaigning, or maybe journalists come to contact the guardian waiting shelter. So there's now lack of continuity to take care of the guardian waiting shelter because the policies are not clear at the moment.
And so, yeah, I think, yeah, just following up on the questions that have been asked, I'm just wondering whether, I assume that this is part of our countrywide, it's not only one district or region, right?
Yeah.
Yeah, so, definitely there must be some thinking around how to sustain them, how to make sure that they are used for the purpose they've been established. So I'm wondering whether, you have some plans, the intention to engage with people in power or people in policy making who might be able to actually influence or engage with the government to make sure that there is some ownership and accountability. Like, I mean, some of these centers could turn out to be centers for disease, for infections, I mean, COVID and other infections that are found in healthcare facilities, infection. So we want to prevent such things, and I'm wondering whether you have a plan to make sure that you can use this information as okay, or you want to identify some partners that can advocate with the government to make sure that these people is taken forward and that this is somebody who's accountable for this center. Right? Yeah. So any plans? I know you did the research. I don't know if you don't take action on things like this, but maybe able to identify partners who might be able to support.
Yeah, I think as of now, the only plan that we have is to make sure we disseminate the results as much as we can. As much as we shared the policy brief with them, but sometimes people in the government would receive an email, would receive a note, they'll just leave it there without even paying attention to it. So we shared with them, and we didn't even get feedback to them to say, can we have a dialogue to understand further how best we can make this or to improve this. So I think currently what we are planning is just to make sure we disseminate the results as much as we can. In December, we also have like a national research dissemination seminar, which we plan also to disseminate the results to, because we know that that audience usually brings in people from Ministry of Health, even some managerial people from the government who may be interested to say, oh, I think this is worse, we need to do something. So I think for now, we just focus on making sure we disseminate the results, and hopefully we should get feedback from them to say this is how we're going to move forward to make sure things are better. Yeah. Sorry.
Maybe just add there, Mindy, as well, just to say that WashTech is also part of a number of sub-technical working groups at ministry of health levels. So these kind of things will get presented at those as well for improved uptake on that side.
Robert had something to add as well.
Well, adding on to that, the original plan was actually do an intervention.
Yeah.
This type of stuff, but unfortunately, a massive cholera outbreak occurred in Malawi, and all of the health facilities had to pivot, and so we couldn't do that. So we had to kind of shift with all of this type of stuff. So it's still in active plans to work with those.
So we had a question about kind of how engaging with the Washington healthcare facilities. Really, and that WashFit has developed a checklist for healthcare facilities. Obviously, it doesn't extend regarding waiting shelter, but it's quite an important point to say, a large part of the healthcare facility infrastructure in Malawi is going to be normal.
how you're engaging and working healthcare facilities. But what encouraging people actually, yeah.
It was a bit too low. I didn't get much of it. Sorry, did anyone maybe get it better? So
It was sharp, right?
yeah, so
How are you engaging with watching healthcare facilities, sort of general movement, let's say, globally? Because guarding waiting shelters have been largely ignored or completely ignored on that so far.
I think so far, look, we have just tried to do it locally, whereby after this data collection, we had to go back to the healthcare facilities to give them the results to say, this is what is happening and how best they can do it. Other than that, we haven't done much, but I think it's a good suggestion that we need to find ways on how best we can make sure this is something,
Yeah, and maybe just to add on the same, we have partners that are working with government, to improve sanitation and hygiene related activities, for example, water aid. But you see that those partners are also supporting, they're putting much of their effort looking at the hospital, not the guardian of the children. So we believe that maybe this would be an eye-opener even at the government partners to start considering the guardian of the children as the mark of the health facility, because the guardian is in the hospital as well. So hope this would be something that would help bring change.
There's a few more hands in the audience. So again, I'm going to encourage people to approach our presenters after the session. But I do want to end now because there is a poster session going on in the lobby from now until 6 o'clock. So please join us there. Thank you again to all our presenters.
Can't see my sweat. Yeah. You might be your name. Spirit now.
Yeah.